Welcome back to HealthTech Remedy. This is another episode recorded live at Health 2025. On the show, we explore how technology and leadership are transforming care delivery. I'm pleased to be joined today by Dr. Lucienne Ide, founder and CEO of Rimidi, a digital health company helping providers deliver connected, continuous care for chronic disease management. And just for confirmation, Rimidi is spelled Rimidi for those who are interested in learning more. Rimidi's platform combines remote patient monitoring, chronic care management, and electronic health record integration to turn data from connected devices into actionable insights for care teams. And Lucy brings a unique dual perspective as a clinician turned CEO, blending bedside experience with deep tech and policy know-how. Lucy, welcome to HealthTech Remedy. It's great to have you with us here at Health.
Thanks for having me. Glad to be here.
Well, for our listeners, again, a reminder, we're recording this live at Health. Thankfully, I think we'll post-process the audio and it should be good, but please forgive us for the audio quality. So I'd love to sort of kick off the discussion before we get into what Rimidi's up to hear about your own career journey and sort of what led you to founding this company.
Sure. So actually started my career in tech, working for the government, and then worked a bit in venture capital, but really a scientist at heart. So decided to go to medical school and thought I would be an academic clinician, did a dual MD PhD, went and did a residency in OBGYN, and had the, I guess, great fortune of living through the paper to electronic health record transition at two major health systems within 3 years. So I think I did 11 or 12 go lives in like 3 years. Children's Hospital, main hospital, inpatient, outpatient, and was a bit shocked and frustrated with the experience that delivered, right? As I think a lot of clinicians were at the time, right? And really thought that we could deliver better technology to support clinicians with what my expectation had been, which is these systems will digitize data and they'll overlay insights and they'll help me make better decisions about patient care, which was not the case. And went back to venture capital to look at emerging health technologies and realized there was an opportunity to bring that first-line healthcare experience to founding a company, because I looked at a lot of technologies who really didn't necessarily understand the problem they were trying to solve. And I became really interested in longitudinal care, chronic disease management. How do we support patients between visits, and how are we as clinicians expected to manage a chronic condition with like 2 data points a year? So that was the origin of Rimidi, initially focused on diabetes management, and then we've broadened out to more chronic disease work. Yep.
So I think that's a really interesting profile for a CEO in this space, because before your clinical background, you had a sense of what the investment landscape looked like, how to put a business together, and the technology side, and then add your clinical experience and obviously research experience as well, and then came back into this role. And I think patients and physicians alike have lived a lot of the disconnected aspects that you talk about. And I always think about when you see a patient in that exam room for their twice a year visit, and you referred to the 2 data points a year for a chronic condition, you're usually seeing the best case scenario. So, someone who's worried about their weight might have even lost a few pounds before that visit. And so you're always like seeing them the most buffed up as possible. I think I read somewhere that there is a sort of in terms of the taglines associated with Rimidi, there's a bit of a like for us by us angle. So I think I read created by doctors for doctors. And I think that says a lot. And can you describe a little bit more about how the clinical foundation and the fact that, you're in the leadership role as a clinician, sort of driving the product development in the company, like how does that influence how Rimidi designs its workflows and assesses impact of interventions?
Great question. So I'm, frequently bring my team back to 2 things. One is the North Star is improving patient outcomes. That is why we are all in this business. And I'm sure we'll talk later about remote patient monitoring, and I'll come back to that because I think it's something being missed in the market and it's really important. But the second thing is it's all about workflow. And, some of my early customers really helped solidify that for me of like, I don't need you to necessarily help me be better. I need you to help me be more efficient. And your software may be great, but if it adds 5 minutes per patient visit, I can't do it. And so I think that just constantly bringing empathy to our customer and saying, you know what, I'll frequently say, because these doctors and nurses want to make their kids' soccer game. They want to be home for dinner, right? There's this human element that we forget about clinicians, that they have a life outside of their job. And so, I think that is a differentiator of the perspective that I and several of our team members bring.
That's a great point. And I think you hit the nail on the head already, leading in with things have to improve outcomes for patients. But also, I do think there's this argument where improving the process for clinicians ultimately improves healthcare as well. Like everything is so hard, and I love your point about people want to make their kids soccer games and like get him for dinner because you know healthcare providers are living every single day in that environment. Well, I know that, a big focus has been remote patient monitoring right now. And could you start maybe for our listeners giving a little bit of a perspective of how widespread remote patient monitoring is and what's really driving the broad adoption across health systems?
This has been a big topic this week in conversations at Health, because we have definitely reached a moment of market maturity, and there are all sorts of different studies, right? That 85% of practices are doing something, or 40% are and 35% will in the next few years. So I mean, we're there, right? Where no longer am I explaining to health systems or clinicians what this is, because I've lived that life for the past couple of years. That in order to sell a solution, I first had to explain to them, what the concept was. So I think we've reached the moment of market maturity when this becomes standard of care, and we will stop referring to it as a separate thing, except for the billing code aspect. But we'll look back and say, how else would you manage a chronic condition like hypertension or diabetes if you did not know what was happening with that patient when they are not in your office? And to your point, they show up in the office, maybe a little thinner, a little bit more teed up, a little bit more adherent to their diet, whatever it might be. And we're not doing them any service if that's all we know about them, right? So I think, that's the conversation we're having with practices, with large health systems, is either, okay, I'm embarrassed that we're not doing this yet as part of our practice because I know it has shown benefit and I know it would help our patients. Or we've been tinkering around with little pockets of this and pilot activities, and it now needs to be an enterprise strategy.
Great. That makes a lot of sense. And it really, if you step back and think about it, doesn't make sense to manage chronic conditions with like episodic, brief glimpses into how patients are doing. Can you explain a little bit more the barriers? I'm thinking about like technology and sort of the classic healthcare things around EHR integrations, device connectivity, all the workflow challenges you already alluded to. What's so hard for health systems in terms of enterprise level solutions? And maybe you could go straight to how Rimidi solves those too.
Sure. There's a lot in that. But I think it goes back to our earlier discussion of like, we have to make this easier for people. We have to make it easier for clinicians, and we have to make it easier for patients as well. So on the patient aspect of remote monitoring and the device connectivity that you mentioned, my learning of doing this for over a decade. So I started the company 13 years ago. We've had the, experience of trying every connected medical device that's come to market for that, period of time. And they've gotten better and cheaper and more accessible and more reliable. But my joke I often say is like, you have an older patient who has a chronic disease, who isn't well managed, and their doctor suggests they do this. And they're not 100% thrilled about it, but they know that they need to because they want to get better. And then you give them a device that needs to pair via Bluetooth to a smartphone that maybe they only use to make phone calls, and they have a little friction in that experience, and you're going to lose them, right? Because they aren't really necessarily invested in being frustrated every day by this thing that their, clinician asked them to do. So that's all to say, we have come to this common denominator of kind of accessibility and user experience, which is give them devices with, built-in cellular connectivity. They just take their blood pressure and it automatically, ends up in their clinician's, EMR. and use text messaging. Nobody wants any more apps on their phone. We're sort of done there. So that's the learning on the patient side. Make it as easy and as possible and remove as much friction. It's kind of the same story on the clinician side, right? This has to be part of their workflow in their existing EMR as much as possible. And I, will tell my team, I don't care if our users don't know who we are and they think it's a new feature that Epic rolled out or Athena rolled out. Like that would be a win because that means that we are, removing friction from that experience. So it has to be single sign-on. There has to be two-way data exchange. And then at sort of the institutional level, right, there's that governance level of friction. It's hard for these big health systems to bring in more vendors and third parties. So we've, adopted the strategy, around 2015, 16, as a lot of progress was made with interoperability of like, we have to be in the marketplace for all these EMRs and sort of invest ourselves in taking as much of that burden as we can off the health system, right? We have to invest in all the cybersecurity. Like we have to check as many of their boxes as we can to de-risk the decision to bring in another vendor.
That's amazing, and I think it can be summarized as healthcare is really hard, and you gotta make it straightforward. And like I think it's obviously you're a clinician, and so you understand how life is in a hospital. But even these few seconds of extra clicking or accessing a different system can be a huge bottleneck, and so you just have to make it completely seamless. Um, I want to also make sure to give a little bit of airtime to kind of the other aspect of making sure that technology is implemented in a way that works for the health system, and that's on the reimbursement side. So I know there have been some evolving changes with respect to the physician fee schedule and opportunities for reimbursement for remote patient monitoring, and based on billing code updates. What does this mean for providers and patients in terms of access to remote patient monitoring?
Yeah, so these, RPM codes first rolled out in 2019. And I think an important thing is that Medicare's been very consistent, right? And they've sort of built on it. They've addressed issues that they've identified with the codes and made slight modifications year on year in the physician fee schedule. And so what they're doing this year was sort of signaled last year by the AMA CPT, body, that there were two artificially determined thresholds sort of historically in RPM. You had to have 16 days of readings out of every 30-day period, meaning a patient more or less had to use their device every other day, minimum, to get reimbursed for that code. And then you had to do 20 minutes of monitoring for that patient to get reimbursed for a second code. And, historically, why did they come up with 16 days and 20 minutes? There's history there. It doesn't matter. But what I think they identified is maybe not every patient needs to take a measurement every second day. There are patients who were leaving out of the opportunity to be engaged through these programs because of that threshold. And maybe not every patient needs 20 minutes of monitoring every month. And so this kind of binary, aspect of you can't deliver care you're not compensated for, was creating a lot of friction in the market. So they're introducing two new codes, one that will compensate for 2 to 15 days of readings, and the other that will compensate for 10 to 19 minutes of monitoring. And so, I think they're going to achieve two things. One is hopefully open this up to a broader patient population who can benefit from the program. Two, I think CMS is going to look at all the data and say, how many patients are getting billed under these new codes versus the prior codes. And ultimately, they want to tie that to outcomes, right? Like, are there better outcomes above 20 minutes of monitoring that we don't see below that? So they kind of signaled that in some of their OIG reports they've done over the past 2 years on RPM. But what I appreciate is they're giving it time, right, to year on year build on the program, collect more data, look at the outcomes, because it's hard for practices if the physician fee schedule changes dramatically year on year. Yeah.
So this obviously sounds like it's added some complexity to this. Is it a net win in terms of patient access and sustainability of remote patient monitoring as a service that will be growing, or is some of this complexity going to be present a challenge?
I think it's net win, right? I think it offers, because as I mentioned earlier, RPM is sort of becoming part of standard of care. People want to offer it equally to all of the patients they think could benefit from it, but it needs to be financially sustainable. So you need these reimbursement models to line up to actual real life patient behavior that you can't 100% control, right? So if you have a patient who only measures 14 days in a month and you can bill nothing for that, that's really hard for a practice. And so this sort of gives them some downside risk protection, gives them a buffer. Um, yes, there's complexity and change. And so I think companies like ours need to kind of shield the practice from that as much as possible. We're doing all the analytics to figure out which code a patient qualifies for and, trying to handle as much of that workflow for them as we can.
Great, thank you. And as I think about these challenges for monitoring and like handling data, one of the things I'm wondering about is how it goes for continuous glucose monitoring because you see people wearing these all the time, and I imagine they output a ton of data. And what's that look like in terms of sort of scaling that at the remote patient monitoring level?
Yeah, CGM has been a hot topic as coverage is expanding, right? That's why we're seeing it as CMS and then the other payers have expanded who qualifies to have a continuous glucose monitor. And we're in this period of moving from type 1 diabetes and endocrinology to type 2 diabetes and primary care. And it's a totally different workflow, right? Endocrinology they have longer appointments, they have more office staff in order to deal with all of the devices that community has leveraged for, decades, years and decades now. Primary care doesn't have that infrastructure to deal with downloading data in the office and analyzing data and getting compensated for that in the 15-minute primary care visit. So it it has put some pressure on the workflow issue of like, how do we bring this data into their workflow at a level that is feasible and impactful? And so it can't be the every 5-minute glucose reading, right? It's the time and range, time and target range, risk of hypoglycemia, GMI, right, is sort of the measure equivalent to hemoglobin A1C, and helping primary care and, OBGYN, high risk pregnancy, whoever it might be, to really use that sort of metadata around the CGM devices to risk stratify and identify patients who aren't meeting goal. I mean, they're sort of one step removed probably from where the endocrinology team is really digging into like that intraday behavior and optimization. We've got to serve up the data to say, okay, I have 2,000 patients on CGM. Who's not doing well? Like, that's the first question. Yeah.
That's fascinating. So you're like summarizing it and giving these really impactful measures that can be looked at like a quick glance or dashboard level. Is that right?
Yeah, because it becomes much more of a population management, game that pairs to, okay, then I'm going to double click on that patient and I'm going to be able to see, what their patterns are, what their issues are, what clinical decision I'm going to make or lifestyle recommendation I'm going to make to help them improve their outcome. But first I need to know who that patient is that needs the time and attention.
That's amazing to see that deployed at the sort of the scale of a full clinic
Mhm.
like that. I'm curious. So there's a lot of outcomes that I can imagine being really impactful for healthcare. There's all these chronic diseases, type 2 diabetes, hypertension, lots of chronic conditions. For say clinicians or for folks who are just healthcare consumers and interested in remote patient monitoring, what would you like summarize in your clinical mind as like the most impactful outcomes that you see? Like sort of what's the pitch for RPM? Like the most compelling example for this?
Um, yeah, I'm super glad you came back to this question because coming off of talking about reimbursement, I am always telling clinicians of like, this is a double win, right? You can get reimbursed to do an activity that's going to improve the outcome that then may circle back to financials because you're trying to improve maybe your HEDIS measures or your STAR measures, right? So it is really the sweet spot of the overlap of those two conversations. But absolutely, you can move the needle on blood pressure control. We have data, a lot of other folks, have shared and published that data of being able to see, again, beyond the 2 data points in the clinic, what's really going on with that individual and more proactively manage medications and titrate medications, right? And get that patient a goal sooner. So I think one thing RPM facilitates is like urgency, right? Instead of feeling stuck as a clinician of absolutely the clinician and the patient share the goal of getting the patient's blood pressure under control most likely, but it's hard to iterate on something that you have such a long lag time before you know what the outcome was. I write a new prescription. I see them back in a year and I say, how did that go? Right. So this shortens that cycle. And then the second one that one of our customers shared some great data with us on is acute utilizations, ER visit, inpatient hospitalizations around diabetes care and rehospitalization. And one aspect of their data that was so interesting was huge effect, right? Like 0 readmissions while being monitored for diabetes care and a dramatic decrease in um, inpatient admissions. But then a tail effect of like once they stop monitoring actively those patients, the patients still benefited, right? So you had like long-term, control that lived past the active monitoring phase. And I think that's what we all need to see.
And is the hypothesis that that's the sort of permanent effects of kind of getting them into the right zone, or is this like behavioral modification? Like people actually respond to that?
Yeah, I think it's both, right? I think it's really empowering to the patient to change the experience from, you know, I, I'm a super engaged patient, right? And I'm reaching out to my practice because I'm not thinking that my, glucose numbers are where they should be. So I'm sending a portal message. I'm leaving a voicemail. I'm playing that game now of is someone going to message me back? And flipping the script on that to someone from the clinic calls the patient and says, we're looking at your numbers. And after we saw you last week and we changed your prescription, it doesn't look like that's really working. Let's make another change, right? That blows patients' minds when that happens. Because for the first time, it's an inbound communication to them. And I think that then builds this self-efficacy for the patient, right? Of like, they feel more engaged. They understand the importance of being adherent to their medication, the importance of testing and having that feedback loop of like, how am I actually doing? So I think it's both. It's getting someone to goal and getting them on the right regimen. And it's the patient education and engagement that drives that long-term benefit.
Yeah, I mean that's a powerful change to the way healthcare is delivered in a sense. And just to reflect on that, I mean, there's so many things that enabled. Obviously, the technology stack and sort of the devices that monitor things, but the reimbursement code is also a part of that. I think the ability for providers to be able to bill for that, because otherwise, the reality is that in healthcare, they're going to be in clinic and they're only going to be able to have time, for their twice a year visit. So I mean, it's really powerful. This to me makes perfect logical sense. Like as a physician, I'm not a primary care doc, but I do have the experience of following up cancer patients, and I know that I'm seeing them on their best behavior, sort of for each of those visits. So I guess one of the follow-up questions is what are your thoughts about making sure that there's some equity in terms of access to these devices? I think I read somewhere that you've done some partnerships with a federally qualified health center as well. Can you give us a little bit more information about how you're thinking about using technology and services to enhance equity?
We do a lot of work with federally qualified health centers. And if the data shows, right, that patients who are generally served by FQHCs and rural health centers tend to have higher rates of chronic conditions than the general population. They also tend to have issues accessing care, right? And for years, there was actually a carve out where FQHCs couldn't bill for RPM. It was considered to be sort of part of their global payment, and there wasn't separate payment. And that got resolved in 2024 for Medicare patients. And I went and did a lot of lobbying on this issue. And we would say, this is addressing the exact issues in this patient population, right? Why am I not coming to see the clinician about my hypertension? Well, maybe I don't have paid time off of work. Maybe I don't have transportation. Maybe I don't have childcare, et cetera, et cetera, et cetera. And so bringing healthcare to that patient instead of requiring that they come to the clinic to get care makes all the sense in the world. So it's really helped that Medicare made that change that FQHCs could deliver RPM and be reimbursed for it. The first year in 2024, it was a different reimbursement code and modality. Then they realized that just confused everybody. And so they've now aligned it to the exact same CPT codes and sort of created equity at the reimbursement level, which is the first step that needed to happen. There are other nuances to this that we have seen, simple things, but like we will text message a lot with patients, as I mentioned, because that seems to be the common denominator of accessibility. You get around what model phone do you have, right? And do you have data plan on your phone? I mean, there are things very simple like this, but that created barriers to equitable access to technology. Then we, through one of our partners at Boston Medical Center, where we've worked for about 5 years, started automatically messaging patients whose data was out of range in their native language that we pulled from Epic. And patients said that really made a difference to get a message saying, your most recent blood pressure reading is concerningly high. Please take another reading in Haitian Creole or in Spanish, right? And so just that mindset of like, the onus is on us to help our providers think creatively of like, how do we meet this patient where they are?
That's remarkable. And as I think about the technology tools available, I mean, all of that, the ability to do a text message in a patient's native language is of course possible with the available technology, but it takes recognizing how to deliver that. Well, I know we're coming up on time, so we only have a few minutes left. I wanted to close with maybe with two sort of broad questions to ask you to reflect on. One about the future of connected care, particularly in remote patient monitoring, and the second more about your career advice. So let's start a little bit with your thoughts on, if you look 5 years from now or 10 years from now with how rapidly technology is evolving, what do you see for the future of the presence of remote patient monitoring and other use of technology for chronic conditions in healthcare?
There are a bunch of technologies on the floor here at Health that it's been fun to walk around and look at. And I think one thing we will see is today's connected care technology is sort of taking unconnected technology and making it connected, right? Like taking a traditional blood pressure cuff and putting a SIM card in it and using it in an RPM program. And that was the stepwise innovation. I think we will start to see more kind of ambient measurement of physiological readings. There are a ton of companies working on camera-based technologies to measure blood pressure through facial scans. Nobody has FDA approval for that yet, but they will get there, right? And so imagine that the mirror in your bathroom every morning when you go to brush your teeth measures your blood pressure, your heart rate, your respiratory rate, your pulse ox, sort of passively. That's the stuff that gets me excited because it's a little, what we're doing today is incremental, right? It is not totally disrupting, all of our concepts of like, how do you take a blood pressure reading? That will be, right? I mean, that'll just be mind blowing, but we have to get there, right? And so I think this foundation that we've established of patient engagement models, reimbursement models is important, and now we can build on it.
Fantastic. All right, last question. What's interesting about your background is that you have you represent several phenotypes. So you have the investor background, technology background, and then clinician background. And then here you are as CEO of a impactful health technology company. What advice do you have for someone who's interested in the field of health technology, wants to make an impact from really any of those backgrounds or from all of them? What have you learned along the way that you would recommend to others who are just thinking about what they can do with their career?
Don't be afraid of what you don't know, right? And and to make mistakes. Made plenty of mistakes. I've done plenty of learning on the fly, figuring it out. Early days, someone said to me, well, you can't start a company if you don't have an MBA. You should go to business school. And I'm like, I think my husband will leave me if I tell him I'm getting another graduate degree. So, I'll figure it out how to build a P&L model. And so, and then, ask for help and be passionate about your vision and what you believe in. And I think that earns you a lot of grace, and people really want to help you if they see that passion of a vision of like, here's a problem I really want to solve. I'm not exactly sure I'm going to get there. And so there's a whole community here that wants to help other folks, make healthcare better.
Well, thank you so much, Dr. Lucy Ide. It's been great having you on the show.
Thanks for having me.
Well, thanks for our listeners for tuning in for another episode of HealthTech Rimidi in part of our special series live from Health 2025. Thanks for joining us and for learning more about health technology applied to effective and equitable remote care. For our listeners, you can learn more about Rimidi's remote monitoring platform and chronic care programs at Rimidi, RIMIDI.com, and follow insights, of course, from the Health 2025 conference on LinkedIn. Thanks for tuning in to HealthTech Remedy. We'll see you again soon.